Alrighty, good afternoon, everyone. As Susan mentioned, my name is Lyle Holmes. I go by my middle name. I don't suggest doing it to your children. But I will be presenting on behalf of myself and Dr. Christine Gold. She's unfortunately out of town, so couldn't be here in person, but was joining remotely. We lead the substance exposed newborn work at University Hospital. So here are objectives for our brief discussion today. I'd like to briefly review the progress we've made surrounding opioid-exposed newborn management at university, as well as to share some of the other work and programs that we've implemented for our substance-exposed newborns and their families. At the end, we'll also identify some of the next steps that we plan to pursue for SEN management at university. So like many of you or your institutions, we started with implementing the Eat, Sleep, Console method of opioid-exposed newborn management with the support of CHoSEN. We have also been contributing and continue to contribute data to the CHoSEN Quick Collaborative or database. As all of you know by now, ESC promotes non-pharmacologic management as the first-line treatment for opioid-exposed newborns. We found that despite some initial concerns about the effectiveness of non-pharmacologic treatment and a birthing person's willingness to participate in non-pharmacologic management, we've seen great success in parental involvement with providing these initial cares, as well as a significant decrease in the need to escalate to medication management and NICU care. I would like to highlight that because our hospital doesn't have a general pediatric floor, we convert a birthing person's postpartum room to family room status, where caregivers and infants continue to room in together even after that birth parent is discharged. At university, we transfer infants to the NICU for pharmacologic treatment when they're unable to function due to withdrawal, despite maximizing supportive measures while rooming in with their caregiver. We're really trying to emphasize the care team huddle involving the caregiver, bedside nursing, and the pediatric provider to ensure that we're truly maximizing all the supportive measures before transferring that baby away from their caregiver. As far as our data, we've seen significant improvement in the care of our opioid-exposed newborns and their families since implementation of ESC. Our length of stay has decreased from as many as 15 to 20 days to now as low as 4 to 5. We've also seen a decrease in medication management for opioid-exposed newborns from upwards of 80% to now as low as an average of 20% or less. Subjectively, we've also seen improved satisfaction both among pediatric providers and the families of these opioid-exposed newborns. Anecdotally, we see that especially highlighted when we have families who had an infant hospitalized who were managed prior to Eat, Sleep, Console and now can compare and contrast those experiences. In addition to this quantitative data for opioid-exposed newborns, we've worked hard at university to implement some novel support programs for all of our substance-exposed newborns and their families, and I'd like to highlight some of those. First off is perinatal behavioral pathways. This program was established in early 2021 as a new grant-funded team that specializes in supporting the perinatal patients' mental health and substance use disorder needs. The team includes psychologists, licensed clinical social workers, and psychiatrists who function as a separate multidisciplinary consult team from the other teams on our unit. They consult both in the hospital and also connect with patients via phone as an outpatient. Perinatal pathways social workers then also connect with patients again after discharge to ensure connection to treatment and referral services. The chart at the bottom, I'd like to just walk through quickly. This shows the data from the Perinatal Pathways team for 2022. At the top, you'll see screen women who deliver at university. What that's referring to is women who are screened for both substance use and depression during their delivery admission. We use SBIRT and EPDS. Next, you'll see the proportion of unique records with positive screens with a behavioral health evaluation within 2 weeks, which is referring to those women who have positive screens who have a behavioral health evaluation within that 2 weeks. And lastly, it talks about case management for women with positive screens, which is referring to the percentage of patients who have positive screens who are then connected to resources. So that chart might be a little difficult to digest, but overall what it's trying to show is that not only are women being screened for substance use and perinatal depression during their delivery admission, but that those women with positive screens are not only receiving timely evaluations, but that they're also being connected to resources and services. Now, we know that mental health and substance use are very interconnected, and although this team is not solely dedicated to patients affected by substance use, we found them to be a huge service to our substance-affected families. I think we've all heard a lot about plans of safe care. We also successfully implemented plans of safe care for our substance-exposed newborns. As you all know, the plan of safe care is meant to facilitate communication and handoffs between the inpatient newborn team, the family caregiver, and the outpatient pediatrician or medical home. This is our plan of safe care template at university. It looks a little long at first glance, but it's actually a really quick checklist that we found helpful to review with our parents or caregivers, care team, and the outpatient pediatrician. Currently, we as the pediatric provider are filling this out at the time of discharge, but we plan to start filing it as a care coordination note so that it can be edited by multiple care team members during the infant and family's hospital admission. I'd like to highlight a couple of things that you'll see in the document. One is that infant requires screening for hepatitis C, which we'll discuss a little bit more in a few minutes. You'll also see that we include the county of CPS report as well as caseworker information when applicable. Lastly, you'll see that we highlight communication with the infant's family and caregivers. We try to be very transparent about the plan of safe care, making sure that the caregiver and family knows that it was completed. We give them a copy at discharge, and we also inform them that it's routed to their pediatrician. In cases when the infant is not discharged with the birthing person, I would like to note that we do delete that person's information and name from the plan of safe care. One of the resources for our birth parents, which we also include as one of the resources in our plan of safe care, is our OB naloxone program. This program, which is provided through the Colorado Naloxone Project, which I think y'all will hear more about later, we initiated it at university in April of 2022, so it's relatively new for us. But OB providers can place an order and give Narcan to our pregnant and or postpartum patients for free. We find that since it's a new program, and especially because we're a training hospital with a lot of rotating residents and trainees, we're having to continue to remind and re-educate providers that this program exists and to utilize it. On the right, you'll see our provider tip sheet for the program with information about how to order the OB naloxone. We, of course, want to make sure that we get naloxone into the hands of all of our patients with opioid use disorder or known opioid use, but we're also working with addiction medicine and other key players to try to educate that there's often fentanyl contamination in other substances, especially methamphetamines, So it's an important thing to consider that even patients who don't knowingly use opioids may benefit from a naloxone prescription. One of the points that I highlighted in our plan of safe care is hepatitis C screening for infants. As many of you, especially healthcare providers, know, it is recommended that all pregnant patients be tested for hepatitis C during each pregnancy because we know that the virus can be transmitted to the infant. We also know that our families or birth persons affected by substance use, particularly those who inject, are at higher risk for contracting hepatitis C. So it's really important that we as pediatric providers look for documentation of hepatitis C testing during the pregnancy. In cases when the birthing person wasn't testing prenatally, we will ask our OB providers to obtain the test during the delivery admission. And then if and when a birthing person is positive for hepatitis C, we're also making sure to include in our plan of safe care and during our verbal handoff with the infant's pediatrician that the infant has certain follow-up needs, specifically testing for hepatitis C after 18 months of age. So we're really proud of the work that we've done for our substance-exposed newborns and their families. But of course, we're always thinking of our next steps and where we want to go from here. Here are some of the areas that we've started some work and or plan to continue to pursue further. First off, the prenatal consultations. This specifically for birthing persons who use opioids, we've had some success with this program when we're able to identify these patients prenatally. That being the key word is identify these patients prenatally, which has been difficult at times. We just heard a lot about EI referrals. I'll be the first to admit that we are significantly lacking in this area and really need to do exactly what Susan mentioned, develop a process for making sure that these referrals are placed when appropriate. The KICS clinic, Dr. Bird Gilmartin at the Child Health Clinic at Children's Hospital, Colorado, has grant funding to start a specialty clinic for children in the foster care system. And we're working with CHoSEN to start a pilot program to connect our substance-exposed newborns in the foster care system with Dr. Bird to connect them there as their medical home. Toxicology testing. We heard a lot about this earlier, which was really timely and important. Dr. Gold and I have spent a lot of time and effort doing our own research as well as a QI project, looking at toxicology testing criteria and addressing our toxicology testing policy to make sure that it's non-biased and evidence-based. And then lastly, but perhaps most importantly, we focus on education. Dr. Gold and I both make this a point of focus. Each month, we have a lot of learners and trainees rotating through our nursery. So we try to highlight the many, many things about our substance-exposed newborn population, but we're also trying to work with connecting with our outpatient pediatric providers to provide more education about these infants and their ongoing needs, since they're the people who follow them long term. And that's all I have. Thank you so much.
Q&A session. All right, next we'll have Dr. Kathi Wells.
So that was a much prettier slide deck than I have, but that's okay. Very nice. Well, I'm actually here on behalf of Jenny Cook-Zappel, who is our program manager, who's not here. She's not joining remotely because she is at Legoland with her family, I think, which we think is a good thing. And we're glad that she's enjoying a little time off. But why don't you just give a little bit of an update of our program? So how many, I feel bad because I know some people may have heard about what we're doing and some people may not have heard about the Perinatal Navigator program. Maybe hands up for those of you that have heard a little bit about it. Okay. So this really came from Susan and I having a conversation about the challenges of how do we know that when these kiddos leave the nursery, especially when you have all done a great job shortening their stay and decreasing their exposure to opioid treatment in the hospital, when they go home, how well do they do? And as a child abuse pediatrician, I can think of many times when everyone was panicked trying to track down where a little one was 2 weeks, 4 weeks, 2 months after discharge from the hospital because they didn't show up with their pediatrician. And also not knowing how long-term outcomes are. So all the hard work that you all do, how do we track those sort of longer-term outcomes? And one of the challenges we know is thinking about all the multiple systems that may be touching families. And it's complicated enough as it is to be a new parent, but then trying to figure out who you're supposed to follow up with when, and multiple different systems, sometimes court systems, sometimes child welfare systems, sometimes home visitation programs, but really not oftentimes having all of those dots connected. And so we talked a lot about thinking about how could we approach this from a standpoint of having someone shepherd them through this process, right? And what would that look like? And the reality is it may look very different at each community or each different setting. And so we initially talked about trying to do this with establishing a navigator that we would host, and that navigator would do outreach and do all this work, and very quickly realized it was really more about creating a structure to how this system would work. And creating the process by what this would look like. And so this is the mission statement that we've recently developed. And we started working really closely with CPCQC and Amber Johnson. I think, Amber, are you back there? Yes, thank you. Who's helped us really say, let's get clearly defining what the mission statement of this program is. And then some QI sort of little projects I'll talk about in a minute that we want to do within that. But really, it's just how do we think about enhancing the quality, equity, and safety of perinatal health care by engaging and supporting pregnant and parenting individuals impacted by substance use through implementing a navigator program that really bridges the gap between the patient's needs and all those systems that serve them while providing some targeted education. And part of this idea was also, and I think, Lyle, you said it really well, is when we can identify folks earlier on, right? How do we get them in that door earlier on? When we may be working with folks that may not be ready or may be fearful of other systems. And it was so great to hear, Diane talk about her journey and remind us that, that fear, and I can remember Jade and I working on this years ago, it's great we have legislation that protects women from being prosecuted for testing positive when they find out they're pregnant or when they're seeking prenatal care. But the potential for loss of their children is by far and above the biggest fear that they have. And so we know this is still a really big challenge, but really trying to figure out how do we move upstream and identify earlier on, and how do we engage them at that point when there may not be other systems like that would engage in the same way. And so we know there are great programs like Nurse Family Partnership, which we think is an awesome program, and it applies to some families, right? Not to all the families. And so how do we think about systemically an approach that could apply much more broadly? So where we're at today with our program is Jenny has been working really hard on developing some toolkits. So the idea being that whether you implement this concept of a navigator through that's someone based at the hospital that is then able to follow that infant and or infant parent dyad, hopefully outside of the child welfare system, but regardless of where they go, can follow them after the pre-pregnancy or during pregnancy, hopefully, time of delivery and hospitalization, and then after discharge. That might be a host of different kind of people that could play that role of a navigator. And we actually didn't even want to get so prescriptive that we said whether that person was a social worker or a nurse, because it really depends. It's really more what their role is and what they do. So that toolkit that really describes sort of what the goal of the intervention is, what are the qualities, what are the things that folks do, and really in that navigator role is that intake process and that shared planning. So when someone is identified as being at risk, how do we sit and work with them and do some shared planning and goal setting with them based on what goals they think they have? I may think they should probably stop using methamphetamine, but their biggest concern may be the fact that they don't have a safe roof over their head or food on the table, or care for their other children in the home. And so that shared goal setting, so a process by which that occurs is part of that manual and that toolkit, okay? The other, when I asked Jenny, I said, tell me what you think the secret sauce of the program is. It really is the combination of someone to help bridge that journey, right? Prenatally in the hospital and after discharge, in a seamless fashion. But it's also a component of nurse education, okay? And that may or may not be the same person as the navigator. I think we originally talked about doing this and having a navigator do all that. The reality is there may be through public health or through someone else that's already based in the community, maybe a very, the right person to do some of that education, safe sleep, a lot of the, developmental needs. As a child abuse pediatrician, we know that when people understand the normal development of their child and understand what's normal, there's less likelihood that they may get frustrated when the baby isn't doing what they think they should be doing. So those things really are key, is doing that in a way. And we know that nurses, healthcare systems are very trusted parties to families. And so that component, so really designing what is the component that individual offers. And then the trifecta we talked about was really peer support. And so when there is an ability to have someone who can provide peer support, like Diane's program does, that really is, I think, the sweet spot. And oftentimes that person's role may be just sort of that lived experience and that connection. I've been in your shoes, but also they may be the one that's helping provide transportation and getting some of those basic needs met. So really, what does that process look like? What are the roles of each of those folks? What are the tools that can be used? What are some CQI initiatives? Those are all things that are part of that toolkit, as well as implementation. So one of the things we know is we may have a really great program with great outcomes, but if we implement it differently every time, then we can't expect the same outcomes. So how do we help support as we design a program and we pilot a program, which I'll talk about in a minute, and then we start to say, well, another community or another entity wants to sort of take this on. How do we help them with readiness planning and thinking about how would they implement this in their community? What tools do they have? What resources do they have? Don't need to reinvent the wheel, right? Capitalize on what you currently are doing well. And so that's really that implementation design part of this process as well. The focus on QI, we think obviously is important. And so it's been, again, working with Amber and really helping to start to design some of those processes. One is around the program you're going to hear Laurie talk about next, right? So really, sort of drilling down on little projects within this larger project. Anybody here from Denver Health? I didn't recognize. So Denver Health, we've been partnering with, and we did this early on because I had been in the Denver Health system and I knew that there is something called Nurse Family Wellness Program that are nurses within Denver Health. You may or may not know that Denver doesn't have its own public health department with the exception of what sits already within Denver Health. So there's public health within Denver Health. And we also had at the Family Crisis Center, where I used to work, which is now called the Safe Center, Denver Health medical team working with child welfare and supported by child welfare for those cases that are at risk of child welfare involvement or in child welfare. And so they have nurses now called Nurse Family Wellness that can work with families when they get referred to child welfare. One of the frustrations we had is if it's someone who's pregnant and they don't have other kids, or if it's someone that got referred because they, or let's say is maybe at risk, maybe the healthcare team is worried about parents' use of marijuana or alcohol use, but maybe doesn't feel that it meets the level to make a report, they couldn't access this nursing program. And so while we had this because of funding, right? So now about funding, because child welfare was paying for that nurse program with federal dollars that they couldn't use to support families that weren't in child welfare. Isn't this a great system we had? So, and honestly, they were frustrated too. I mean, child welfare actually wanted to help those families, but they couldn't use these nurses to do it. So we started working with them and said, wouldn't it be fun to pilot a project like this with them? And then they were able to get some funding through the mom grant to actually fund some components that we weren't equipped to do. So they're implementing some of those components that we have helped co-design with them. And we'll be studying to see how that goes. They just took on, I think, their third patient, and working with them, and we'll do some QI sort of projects within that and do some tweaking to determine where we want to modify the overall structure. But that's, I think, an exciting sort of first step is to pilot there, and then to think about expanding the program. And so what we mean by expansion is, again, it's that concept of this overall implementation project where we have this design of a navigator system using a nurse education and some peer support, but it may be implemented in different communities differently. So how do we help support that be implemented in other communities and collect data? See, the other piece of it is we want to collect data. And we have signed agreements between child welfare and healthcare systems now that we're working on being able to show that if this child goes through this system, can we tell that in 6 months, in a year, in 2 years, there's less penetration into the child welfare system? Or if there is, it's less deeply, or it's for a shorter period of time. So those are longer term goals, and they take a little longer to sort of be able to see those kinds of outcomes. But that's our hope, right? Is that not only do we see mom baby dyads together healthier, longer, but we also show less penetration into the child welfare system. And so then that's sort of that statewide resources to support program expansion. As Jade mentioned earlier, our partnership with Illuminate and with the lab to really thinking about how do we take this design and then give people through toolkit support ability to implement this in their communities as well. So isn't this is like an oxymoron slide, right? Anybody could have said challenges, data and funding, but that's sort of our biggest, in moving forward. But we're just so appreciative to be connected to the CHoSEN initiative and working with all of you in thinking about how we can push your work out to show that what you're doing to impact infants in the hospital, and even hopefully more and more prenatally, and then as they come through the hospital, that their longer term outcomes really mirror what you're seeing in the hospital as well. So thank you.
All right. Hi, everybody. Thanks again for having me. My name is Laurie. As Susan said, I've met some of you, but not all of you. So good to meet so many of you, like Susan, in person for the first time today, and some of you for the first time in any, virtual or in-person space. Okay, so today we're going to be talking about, broadly speaking, passive strategies to engage pregnant women with substance use. And I deliberately did not design this presentation to only focus on our little project, which Kathi and others have mentioned, because obviously I'm biased. I think our project is pretty cool, but there's a lot of ways that you can kind of morph this approach that can look really different and can be, I think, nicely tailored to whatever you may be trying to do. And so I'm going to introduce this broadly, and I'll kind of briefly talk about our project as an example. But I think there are lots of examples that are out there that are really cool. And I'm going to try to highlight as much as I can in a short period of time. So, oh, look at that. Title slide ×2. No special disclosures, unfortunately. Learning objectives, you can read these on your own. But essentially, the idea here is we're going to talk about why I think this approach is cool and how to do it. Some examples. So what am I talking about when I talk about passive recruitment? So passive recruitment is really a business idea. I am not a business person. I don't do that. I don't get it. My wife does that. It's very confusing. So this is like the dumb version for people like me, which is that passive recruitment in the business world is when you're basically recruiting somebody who isn't looking for a job. So like headhunters do this, right? They might, pluck someone out of their current position and say, I know you're really happy with your job, but I have something even better for you. And this is, sort of a strategy in the business world for, achieving certain means that, again, way above my pay grade. I don't get it, but this is what they do. So in healthcare, I think you can understand how this can be pretty easily modified. We have, not just in the pregnant substance use space, in the general, healthcare world, we have a lot of patients who, for whatever reason, aren't seeking care, even though we think they probably should be. And we feel like we have lots of reasons and data to support that if they were to engage in care, they would, live longer, be healthier, probably, we hope have a better quality of life. And yet they're not engaging. They're not looking for care. And so, I think there's a nice parallel here and potentially some lessons to be learned. I think in our setting, when I'm talking about pregnant women who are potentially, struggling with substance use disorder, it's almost one step further. Not only are a lot of those women, not necessarily actively seeking out prenatal care, for example, or substance use care, they are often actively avoiding it, right? They are taking every conceivable step to not end up, in the emergency department if they can avoid it, right? They really try very hard to avoid the healthcare system, and we'll talk about some of those reasons why, but I think all of us in this room probably can identify what some of those reasons might be. Now, in the healthcare world, you can sort of take this another step further in terms of how to passively recruit somebody. Again, in the business world, the passive recruitment refers to the passive part is on the sort of recipient end, right? So the person is not looking for the job, but you, the headhunter, are still actively trying to go find them. I like to take this a step further and say, not only is my potential, target patient not looking for healthcare, I am not going to go chasing after her either, because probably it's like a dog, right? If you go chase a dog, the dog runs away because it's a game and it's fun. And unfortunately, I think sometimes when we come on really strong and enthusiastic with some of these moms, it's super intimidating. And it's understandable that a lot of them just sort of say like, no thanks, I'm not interested right now. And so there's a role for that. I also think there's a role for taking another approach that is not so active in terms of trying to capture that population. So passive in two senses. Okay, so why? Why is this a nice approach? Or rather, for which patients is this maybe a better approach? So there's this thing called the social desirability bias, and this is a major problem in a lot of toxicology research. Susan mentioned I'm a medical toxicologist, and this is a huge issue, right? If you ask somebody, you walk up to them and say, "Hey, what drugs did you use today?" What do you think they're going to tell you? None. I didn't use drugs today, right? And when you have a human-to-human interface, we all understand sort of intuitively what the answer is supposed to be. And that's probably what we're going to say unless we have a really good reason to not say it. And unfortunately, I don't think we do a very good job in healthcare of establishing really good reasons to, not say the socially desirable answer. And so in a passive approach to recruitment, this has been trialed in research studies looking for participants to answer questions basically about their drug use. This has nothing to do with pregnancy, just in general. We found that using passive approaches to like participant recruitment, for example, is much more successful and also yields more accurate answers to questions. And so, there's something to be said for, again, not necessarily having that human kind of face-to-face interaction when you're concerned about social desirability, biasing the answers you get. We talked already about how a lot of these women are not just not seeking care, but are actively avoiding care. And so, good luck trying to find somebody who's never showing up to your healthcare system, right? Like, how are you even going to logistically manage to connect with her? She's not there. There's a nice option for asynchrony. Somebody I met with recently told me this is like a consume when you're ready approach, right? So like right here, right now, when I happen to be working my shift and meet you in the emergency department is maybe not actually when you're ready to talk about change. But if we have a passive approach that allows this person to connect when she's ready, then she has that opportunity. And maybe that's at 2:30 in the morning when everyone's understaffed, right? But that might be when she has her moment. And you want to have a way to capture her then, and not say, well, if it's not between business hours, we just can't help you, And kind of along those lines, it also allows for a one-sided exchange. So, that asynchrony implies that she can connect when she's ready, even if you're not necessarily awake and ready to receive that referral, and vice versa. You can hopefully send information out into the ether in a way that she can hear it when she's ready. And I keep using she, her pronouns, but I'm doing that mostly out of convenience and not because I imply that every person in this, category is identifies as female. So here's a fun fact. Everybody got a smartphone these days, everybody. And that's really useful because smartphones are really powerful. I learned recently from a friend of a friend of a friend that, and I don't, so, asterisk here, have not personally verified this is true, but it made sense to me that I guess today's smartphones are equivalent to like 25 times the computing power of what was utilized to send the Apollo mission to the moon. So these are really cool. They can do lots of stuff. And we probably don't use them as much as we could in innovative and novel ways. And interestingly, there's this whole field that I learned about in the last few years that probably some of you are way more familiar with called mHealth, mobile health, mHealth for short. And people had this idea long before I did that like maybe we could use this really cool, powerful computer thing that everybody has in their back pocket to do something about targeting these difficult to reach populations. So here's a cool study that I will just very briefly summarize for you. It turns out HIV is a big problem in a lot of places, including South Africa. And in South Africa, there is and I imagine this is true in a lot of other countries too, there's a huge problem where, we're getting better at identifying people with HIV, and our ability to actually get from the I diagnosed you with HIV to I connected you to healthcare specifically for your HIV, there's a gap there. And part of that gap is probably much like with substance use, there's a lot of stigma, there's a lot of shame associated with this diagnosis, and there's a lot of active avoidance. Like if I just bury my head in the sand and pretend it's not happening, it's going to be fine, right? We're just not going to worry about it. Turns out that's not very good for people. So these folks, this was a pilot project, and they essentially developed an app that you could load onto your smartphone that did a lot of things. It helped connect people to care in terms of like literally being like, here's how you can schedule an appointment, and it like walks you through how to do it. And here's who you need to schedule an appointment with. And it offered reminders and little like pop-ups with little like blurbs as far as education. Did a lot of cool stuff. I'm not going to get into the details. Bottom line, this was a randomized controlled trial where they assigned newly diagnosed individuals to either download the app or just nobody talked about the app. We just normal care, right? Like there's still a referral and all that jazz. And it turns out it was pretty cool that for young people, this laser pro, yeah, okay, cool. Can you see that? Barely. But trust me, it's here. If you looked at the control line here, the number of people, this is NLC is not linked to care and LC is linked to care. This column is in this 2-week to 8-month period. So did somebody, get linked to care for at least somewhere in this time frame? And then did they ever link to care? Like, did they make an HIV related appointment at any time? Yes or no? And it turns out people did better, right? You had higher rates of linked to care and lower rates of not linked to care in the intervention groups, both in the time frame listed here and then in the ever group. So, that's pretty cool, right? Like this was a relatively, simple intervention. Like, can you just download this app on your phone? And it did a lot in terms of getting people to open the door. So this is our program. We are not that cool. We don't have an app, but we do have a QR code, so that's kind of cool. Our program is really intended to utilize this passive approach, which I've talked about, but I'll delineate in this context in a moment, to try to capture women who are presenting to emergency departments. And I recognize that this current version of the program is not addressing women who are avoiding the ED, but we know, we have data from our own institutions that women with substance use active substance use during pregnancies do show up to the emergency departments, even when they're not showing up to their prenatal care appointments. And that's actually a fairly common phenomenon. The other phenomenon that's pretty common is new diagnosis of pregnancy in the ED in a substance using woman. So she may not know she's pregnant and then learns she's pregnant in the ED, and then she never comes back into contact with care until she delivers. And so to try to capture that population, we designed this flyer, which you may or may not be able to read, but I can email to whomever wants it. And we deliberately tried to make this really brief and not overwhelming. And we really focused this on like sort of highlighting what we could do for clients. So, hey, you're having a baby, like, guess what? That might be news to you from 30 seconds ago, but it's happening. And many people, I envision probably don't feel very ready. And here are some of the ways that we can help you feel more ready. And if you currently or previously use any of these substances, you could participate. Here's how you can sign up. And the idea behind this flyer, in its inception, we wanted to just basically put this everywhere, right? Like you could not walk through the ED without seeing this on every face of everything, to make it very normal. Everybody would see it. And the nice thing is, this does not require that anybody notices that you're pregnant. This does not require that anybody knows that you use substances, right? And so if you decide that today is not the day you're going to tell anybody about either of those two, it doesn't matter. You still see this information. You still have the opportunity to refer yourself to the program. So the QR code will take you to a REDCap form. We use REDCap for ease. It doesn't have to be REDCap. You just need any place where you can sort of store information. And we ask, as you can see here, again, it doesn't really matter the details of this form, but the point is this is the whole thing. It's really short. It takes you about maybe 30 seconds to fill this whole thing out. You can do it while you're going pee in the bathroom. And we ask you your first name, how you like to be contacted, and when, and that's it. We don't get into the nitty gritty here. That happens later. And the idea, again, is that we're trying to make this really fast, really easy, something you could do surreptitiously if you needed to. And you can again designate, like, don't call me when my boyfriend is home or whatever, right? If you want or feel the need to, kind of set limits around that. For the 4% of reproductive age women who don't have a smartphone, there is a telephone number that you can call. There's a URL that takes you to the same REDCap page as the QR code. And we've asked the staff in our hospital where we're piloting this to basically, we've coached them to be very, very brief when discussing this. So this is not intended, if somebody asks a question about this is not intended to be, a long heart-to-heart about substance use and pregnancy. In fact, we deliberately want to avoid that, right? The whole idea is to not have that interaction happen because we don't want people to be scared off. If somebody opens the door herself and says, I want to have a conversation about this, that's great, go for it. But we don't want that to be sort of forced upon women or pregnant people. And so we've coached them to just say, if you want, I can help you use a computer if you need me to open this page for you. And that's it. So we have that opportunity to all the rooms, the ED rooms in the university hospital where this is being piloted have a computer in the room. And so the staff knows that they can use that computer to open this link if the person does not have a smartphone or doesn't want to use it for whatever reason. So that's cool. And it turns out that we have had a lot of people scan our QR code, and we've had basically no one actually take that second step to filling out the form. And that was a bit of a surprise. I thought it would be one or the other. I didn't expect this sort of middle ground situation where people scan it and then something happens and they get cold feet and they don't actually fill it out. And so we recently had a nice meeting with some folks from Tough as a Mother and Storyboard and discussed the possibility of trying to, again, make accessible a passive but maybe more humanized way to connect folks who maybe took that first step of scanning but aren't quite yet kind of over the hump of taking the next step to filling out the actual intake information. And so the idea, which I thought was brilliant and was not mine, was to actually have our navigator. Sorry, I just realized, I don't know that I made it clear. I think this was implied earlier. Kathi said this, but I should clarify. This program feeds into the navigator program that Kathi just talked about, for those that missed that innuendo. So the idea was that we would have our navigator, her name is Mandy, actually record a video using the Tough as a Mother platform, basically just introducing herself and being like, "Hi, I'm a human, I'm a normal person, and like, come talk to me. It's not scary, it's cool." And we thought that was a really cool idea. Mandy's on vacation right now, so I am 100% jumping the gun and saying she's totally going to be on board and is going to do it. But I think she'll be supportive of the idea. And we decided we were going to, hopefully, if Mandy's on board, embed that in the in this. There we go, this REDCap survey. So at the very top, basically before you even get to the part where you are asked, like, what's your name? You see this video pop up that's short, that's just an introduction. Like, it's not just a random like computer algorithm that's getting this information. It's me, a human being, and I'll talk to you and it's gonna be fine. We also talked about potentially creating a mashup for those who are not familiar with Tough as a Mother. It's phenomenal. Please go to their website and check it out. But they have this opportunity for moms who are in recovery to share their story. And the videos that they have are incredibly powerful. And they are working on actually trying to design like kind of a mashup of a bunch of moms of what they have already available, targeted towards this program, this QR code referral program, to sort of say like, hey, I did it, you can do it too. And I'm hoping that that might add an extra little zing to our REDCap form that will help get people over that hump. The last thing I want to highlight, and I don't know how I'm doing on time, so if I'm going over, you can just like yell at me and cut me off. Great. Is social media. So full disclosure, I have a Facebook account. I think I logged in last time like about 8 years ago. I don't do any of the other social medias. I don't even know what all their names are. I'm very bad at this. This is like not my thing. But I hear other people do it a lot. And it sounds like a lot of people get a lot of information on social media sites. I'm exaggerating a little bit, but I really am like pretty much that dumb about social media. But there is really good data that suggests that this is an underutilized tool. And businesses, by the way, get this. They're all over social media to honestly like it sounds like intense irritation of like every consumer of social media. But the reason is that it works. It gets to a lot of people really fast, really cheap, and you can also, in like incredibly creepy ways, target people in ways that you did not know were possible, and again are like extremely disheartening. But it's also useful. So here's an interesting study. This was a group that was based in India. And for a bunch of very interesting socio-political historical reasons, anemia among reproductive age women in India is a big problem. Not only is it just an very active public health problem that affects a lot of women, the government has invested a ton of money into trying to address this problem, and they've basically not been successful, bottom line, for, again, a lot of different reasons related to, in some cases, like educational level of women, a lot of misinformation about anemia and iron supplementation. There's just a ton of reasons why this has been very difficult to tackle. But the point is that identifying which women might be anemic, identifying which women are anemic, and then need iron supplementation and are going to be reticent about taking it for whatever reason is a challenge. And so this group did kind of a pilot to try to use Facebook ads to identify and then educate women about iron supplementation for anemia. And the details here don't matter. This is not really our population of interest. What I want to highlight for you is that they did a couple different things where they had some ads going, and in this 1 day period, they had 4,843 women in their targeted geographic area respond to this survey. That is unbelievable. Then let's see, over here, they had what is that, 2-ish month period of time, not even 2 months, where they reached 1,151,471 women. That's crazy. I could never dream of numbers that high, right? Like this is just well beyond the scope of what we typically talk about. And so, yeah, like I'm sure that not all 1,151,471 individuals were like anemic women, but some of them were, and some of them know anemic women, and some of them, told their friends something interesting about anemia. And like, this is how socialization works, right? And so utilizing social media to try to spread messaging in a targeted way is, first of all, unbelievably cost effective if what you're trying to do is just spread the word, right? Just to give you guys a sense, you can do things like this for anywhere between about $500 to $2,500. So it's not that expensive. We're not talking about, hundreds of thousands of dollars to reach literally millions of individuals. So hopefully moving forward, we actually did talk with Tough as a Mother about potentially piloting some social media campaigns to actually get that QR code out there. Again, it doesn't matter. It's not a big deal if this gets into the hands of literally 1 million people to whom it doesn't affect. It's fine. There's no harm done there. If I tell people if I could put this on every billboard on Colfax, I would. But this is probably a much more effective way to get it into young people's hands and just to kind of increase this passive awareness so that at 3 a.m, if that's the time that you decide you want to scan the code, you can go on TikTok or on Facebook or on Insta or whatever and pull it up and do it. So with that, I'd love to offer some thanks to a lot of people who have helped me a lot with this project, and we'll turn it back over to Susan. Thank you.
All right, 3 awesome presentations. We've got a few minutes for questions. All right, I'll get it started. So question for, where's Lyle over there? Okay, so at the university, university is a big hospital. There are a lot of OBs, a lot of midwives. You've got your pediatricians. You've got a lot of neonatologists because I work there. And those are just the physicians, right? In terms of the nursing staff, it's hundreds and hundreds of people. So how do you get them to buy into all this that you presented?
That's a great question. And exactly, honestly, what we struggle with. We do have bi-monthly meetings for our substance exposed newborn and substance affected family work, where we talk about all these issues. And we invite everybody to join us. If you're at all connected with the university system, please come. But a lot of it's just sharing over and over and over again through all the key stakeholders. So that's not a great answer, but just trying to say it multiple times.
Other questions?
I had a question for our last presenter. Is there a way that if a person at 3 o'clock in the morning wants to talk at that particular point, but wants to talk to the person that's going to be more like receptive to that conversation, there's no way for them to do that? So right within your program currently? Okay.
Pass the mic over.
I
Do you
have
have more?
question, yeah.
Don't answer until she's done. Okay.
I'm like, wait.
Okay.
And with this social media kind of platform that you're considering using, how are you going to take on all of the potential patients that you're going to get? Because that could potentially be really big, especially in the Denver metro area. I mean, that's a lot to think of. I can't
Thanks. Yes, and yes on all counts. So you're totally correct that if somebody decides they want to connect somebody at 3 a.m, I don't expect Mandy to answer her phone at 3 a.m. So we, again, the disadvantage is that if you want to have a synchronous human to human interaction, this approach is deliberately designed to not really focus on that. Now, granted, this whole process is meant to facilitate kind of capturing somebody, right? Like getting the referral to actually be completed and have somebody kind of enter a program, in this case, the Perinatal Navigator program, which is very much a human to human, kind of real time interaction based program. And so there is this potential for somebody who's not only interested in engaging at 3 o'clock in the morning, but wants to take that next step and like do the entire intake process at 3 a.m. We don't have a mechanism for that right now, although pie in the sky, maybe one day. But I hope that this is, a kind of novel and reasonable approach for certain women who are unlikely to otherwise engage, period, to get them over that kind of initial like intake hump. And then moving forward, if they're willing to engage, the whole thing revolves around human to human interaction. So I think it's sort of a detriment in the beginning, but for the purposes later on of definitely having that, ad nauseum. The second point, we have talked about this potential for just a massive flood. I would be so delighted to have that problem. Sadly, I don't think I'm going to have it, to be totally honest. But if it happened, like we are so lucky to have so many partners in so many places that I think we could manage it, at least initially, to say, oh my gosh, we got this massive, kind of intake need, and we need to start kind of quickly like siphoning some of these to other places. And we actually have identified some community kind of resources that we can, at least for some individuals, probably link them to that have capacity. So we have a sort of a backup plan for that situation. But I think the real answer is we've all talked about this and we've all felt like, what an amazing problem that we probably won't have. But I hope I'm wrong.
Question. So I'm curious, a little bit of follow-up from when you could track and see that folks were clicking the QR code but not doing the intake form. What led to your conclusion that the reason for them not doing that was that there wasn't a human on the other end? Was that just speculation of what you think may be occurring? Okay. And any way to, sorry, I see the verbal head nod. And any way that you have entertained maybe more accurately understanding why they're opting out, like maybe even having an option to capture that of like, I landed here. And I think of myself, like personally, if I saw that and I landed on a page and they're asking for my information right off the bat, I would also be like, nope. Not whether it's a human on the other end or a robot. I just think it's like, it feels to me a little invasive. Yeah. That could be my own personal view.
Yeah, I mean, completely speculatively, I think you're exactly right. I mean, that's what our suspicion is that, it's like the first question is like, what's your name? Which is inherently identifiable. And so I think there is, again, completely speculatively, I think there is this component of like, sort of a fight or flight freeze kind of moment where you're just like, oh, I don't know if I'm ready to like actually spell out my name for you, right? And so we hoped to overcome that barrier, which we, again, completely speculate and don't actually have data to support that is what it is, with kind of a, like a human being messaging, like, this is who I am. This is as the navigator receiving this information. This is what I'm going to do with this information, right? And what I'm not going to do with this information, which I think is more the concern. And we hope that is one way to overcome that. To your point, we don't actually know if that is the primary barrier. That's just our thought. And I think it's a great idea actually to potentially offer someone the opportunity to explain why, like, never mind, I'm not ready. Now's not the time, or whatever the reason may be. So I think that's a really cool idea. If we could embed that into our survey, it might be interesting to see if anybody submits anything. We have, used a lot of previously published qualitative information to try to build this the way we did. And, obviously that's limited in a lot of different ways. But it wasn't like for the record, it wasn't just like me and a bunch of other people like making something up. It's pretty close to that, but it's slightly better.
I was just going to add to that, because during a pregnant period, there can be, or at least we've seen other examples of people that advertise one thing and then actually advocate for the opposite for pregnant people. So I wouldn't be surprised. I didn't see it on the screenshot you included, but I don't think it mentioned like, you will not be arrested for saying you are consuming, something like that. So they might get to the point where if this is my name, this might go to someone who's going to get me in legal trouble. Yeah, so I wouldn't be surprised if it was the, oh my goodness, wait, now you want my name, but if I say I'm doing something, I'm contacting DPS, I'm contacting law enforcement, or I'm contacting like your healthcare provider, something like that. So I wouldn't be surprised if it's just that, like, oh God, I'm not putting my name out there.
Questions? All right. Well, thank you all to our three presenters. I think they're really exciting projects. And I have no doubt that we'll continue to hear more in the coming years.